Wimberly. I'm the Executive Director of the Addiction Prevention Coalition. We are a nonprofit in Birmingham, Alabama, and we are thrilled to have each of you here and to be able to offer our very first professional development training around substance use disorder and addiction. This is something we've wanted to do for a very long time. And have not been able to make it happen, but all the stars have aligned and we're excited to be here, very excited about the topic and the presenter. And I know that each of you is going to be blessed by this time today. I wanted to just first of all introduce Ashley. She's going to be leading with the logistics and answering all of your questions. She is our prevention navigator, and she's also our director of continuing education. And also wanted to thank our partners, and that is Not One More Alabama and Huntsville, and Drug Education Council in Mobile are partnering with us to be able to offer this statewide. So there'll be a survey. We want to get your input about the presentation and also future topics. We're already working on several more for this year, and I don't want to keep speaking, but I just wanted to tell you how grateful we are that you have taken the time to join, and I'm going to turn it over to Ashley.
All right, good morning, you all. It's crazy to see that we have almost 225 people here already. So I'm actually just going to go through some of the logistics stuff for CEs. So let me share my screen and pull up this presentation real quick. All right, can you all see that?
Mm-hmm.
All right, perfect. All right, so of course, you know, this is Addiction Addressing Stigma in Medicine. We have been approved by the Alabama Board of Social Work for 2 contact hours. And it actually came to my attention this morning that on the Alabama Board of Social Work's website, our expiration date was listed as 2021, which is actually our approval date. So the expiration date is actually February 22nd, 2023. And that is something that they should be taken care of by this afternoon. We've also been approved by the NBCC for 2 contact hours and the Alabama Board of Nursing for 2.4 contact hours. So as far as going about obtaining continuing education credits, in normal times you would sign in and do that whole process, but what we're doing here is I'm asking that you all change your name on Zoom. So you should be able to go to the 3 little dots beside your name and change your name if it's not the name that needs to go on your certificate. After the presentation is completed, the Zoom page that typically comes up on the web page, which is known as the post attendee page, should pop up, and it should pop up directly to our survey evaluation. And then we're also going to put the evaluation link in the chat box, and then I'll also email it out to you guys as well after the presentation. On our evaluation, there's going to be a page where you select if you need continuing education credits for the nursing board, for the social work board, or the NBCC. And then you'll just select what you need. And then certificates will be done within 7 business days of today. And then if you guys have any questions, my email is on there, and I will also put my email in the chat box as well. All right. And that is all I have, and I will turn it over to Bronwyn.
Thank you. Good morning, all. I am so happy to have you here. I am going to share my screen and get this going. So, good morning, welcome. I'm excited to be here with you. Always start with who am I? So, you know, my name, Bronwyn McInturf. I work at the University of Alabama in Birmingham, and I direct addiction services in the Center for Psychiatric Medicine. I have a master's degree in social work, and I have been in this field now for over 20 years. I entered the field thinking that I would, do some public service work and work in the field of addiction, maybe 5 years, and then had a thought that I would then go into private practice. Well, that never happened. And it never happened because I just fell in love with what I do, where I do it, who I work with, the patients that we serve. So I'm really glad that I get to present on topics like these and share it with other people who love this field as much as I do. I am not a person in long-term recovery. I am a strong ally for people with an active substance use disorder and those who are recovering. So that is me. And who are we? I wanted just to take a few minutes to tell you about the work we do here at UAB's Addiction Recovery Program at the Center for Psychiatric Medicine. I think talking about this work gives you a little bit of insight into what is possible in the world of caring for those with addiction, as well as the scope of my practice and things that may come up for you or questions you may have as we go through this. You can kind of see the pieces that I do. And as Ashley said, she is the driver today. So she will come in and stop me at any time if people need anything. So, okay. We have inpatient detox here in the Center for Psychiatric Medicine, and that is for medical detox, complex detox. Those stays are brief stays for stabilization and the medical and physical safety of our patients. We have intensive outpatient treatment. Right now, we are doing that via Zoom. And that is care for our patients, adults with a substance use disorder who come now Zoom with us daily, 9 a.m. to 12 p.m. for interventions for substance use disorder. When someone has completed care, we continue to offer as part of the treatment continuing care, which is group therapy weekly for up to 2 years. We have family services here. So we believe that substance use disorders have a profound effect on the person with the disorder, but on the family as well. And it is very important to us to care for the families, educate, and provide them support. So we have 2 family therapists. They work with our families that are in treatment. They can provide some support during continuing care. They help some with our consults, which I'll talk about in a moment. And they also provide support to the community. So we have a free family support group every Thursday evening here at 5 p.m. Of course, the families who are in our program attend it, but it is open to all and just one way that we want to serve our community. We do professional evaluations, and that is with licensed professionals, many of them, if there's a concern they have a substance use disorder or they have reported that they have one. The first step is often to get a professional evaluation that provides a roadmap for treatment and for that person being able to return to active practice, which is always our goal. We do consults, so we go house-wide. And if y'all know UAB, you know our house is a big house. So our consult team is an interprofessional team consisting of physician, nurse practitioner, social worker, counselors, and our wonderful peer support specialists, which I will talk about in a minute. So they go bedside anywhere in the hospital. That includes the ER, that includes our Highlands campus. Anyone can place a consult to have addiction medicine team come see the patient. And we see patients for a variety of reasons, helping with a treatment plan, helping with linkage to treatment, support. Our physicians may consult about treating complex withdrawal, helping to speak to the patient about medication options after hospitalization or during hospitalization. We recently, I think it was October 2019, formed a partnership with hepatology and the liver transplant service to work with patients who have an acute liver issue and may need a transplant. We work with those patients, mirrors what we do for our professionals. We do evaluations with the patients, looking at a roadmap. What does that patient need to do, and what does recovery or stabilization need to look like for them to be able to be listed for a life-saving liver transplant? That's been an exciting partnership, and maybe, I've heard, we have one coming up with heart transplant as well, which is exciting. We offer peer support services. We have 4 full-time certified recovery support specialists. That is the name. We call them here peers. They call themselves peers, but the official name from the Alabama Department of Mental Health, who certifies them and trains them, is a certified recovery support specialist. So that's 4 people here full-time who have a beautiful lived recovery experience, have specialized training through the Alabama Department of Mental Health, and bring that experience and that support to our patients here. And our peers help in lots of these different clinical care areas. They provide services to our patients in detox, in our treatment program. They go house-wide as well for consults. And so that's been wonderful. And we'll be talking more about them later in this presentation. And just to give you an idea of some of the services and the specializations that our therapists have here, because as we know, of course, we want to primarily treat the disease of addiction in our programming, but people with substance use disorders often have other comorbid issues. So our counselors, we have them trained in EMDR, DBT, CBT. We have a CSAT on staff. When we're not in COVID times, we do equine therapy, and we have a grief specialist here as well. So Ashley, did anybody, I saw some hands raised, and I just kind of moved forward unless you stop me, Ashley, you're the driver.
Nope, you're good to go. I'm taking care of raised hands.
Okay, thank you. You just let me know. So thank you for letting me share a little bit about me and what we do here. And before we delve in, the few recent trainings that I've been to, and one was a peer training. It was actually not for recovering peers, but for healthcare professionals, helping healthcare professionals training that I went to. They start the training with just a brief settling moment to help focus, to help the information that comes in today, have a fertile field to grow, and just help you. I know it's very hectic getting somewhere, starting, so it's nice to start a program with just a moment to settle and begin to focus. So we will only take a moment. If you feel comfortable, I won't know because I can't see you. If you feel comfortable, I want you to close your eyes and just feel yourself settling in to yourself. Feel yourself connected to the chair or the floor. Notice your breathing and pay attention to that. There's no special way that you have to do the breathing. Whatever way your breath comes in and out is just right. Just take a moment to pay attention to it. To let the thoughts drift past. and prepare yourself for today. Let's take a couple of deep breaths. And when you're ready, slowly open your eyes. And let's dig in. All right, let's get started. We are here to talk about stigma and addiction in medicine. I start presentations typically with a little background and definitions, just to make sure that as I'm referencing things, you know what I'm referencing. So this first, it's really a reference to stigma, and the reference is to a definition from Lincoln Filon, a sociological definition of stigma that they published in 2001. So the reference says prejudice, avoidance, rejection, and discrimination against people who have a socially undesirable trait or engage in culturally marginalized behaviors, such as drug use. So literally in the definition of stigma, the poster child for stigma is drug use. And the second definition is another one from sociology, from Goffman, but it hit me as referencing the impact of stigma. And so the definition from Goffman is stigma, an attribute that is deeply discrediting and that reduces the bearer from a whole and usual person to a tainted and discounted one. And that was very powerful to me to think of the patients that we work with and having an attribute that is deeply discrediting and our patients feeling reduced from a whole unusual person to a tainted and discounted one. There is a reference, a great site for you to go to out there is the Recovery Research Institute. Leadership of that is Paul Kelly and Michael Botticelli, who we'll be seeing later. And one of the quotes in the Recovery Research Institute is substance use disorders and opiate use disorders in particular are among the most stigmatized conditions in psychiatry and indeed throughout societies more generally. Such stigma leads to fear of discrimination and negative repercussions that prevent or delay sufferers from seeking treatment, leading to a greater morbidity, so death, and mortality risk of death. So it shows you, and we want to look at what we have here, the definition of stigma, and also start to look at how does that translate for our patients. There's another quote from leadership of the Recovery Research Institute and some research out there, which I can't share all the research, but when they look at surveys worldwide, the most stigmatized health condition is illicit drug use. Most stigmatized health condition worldwide in surveys, illicit drug use, and very closely followed after in the lineup is alcohol use disorders. So it's certainly very relevant. So we've given the definition for stigma. Let's look at addiction. Quick primer from the American Society. We'll first look at the definition of addiction from the American Society of Addiction Medicine, which we refer to as ASAM. The ASAM was founded in 1954. It's a professional medical society representing over 6,000 physicians, clinicians, and associated professionals in the field of addiction medicine. The ASAM is dedicated to increasing access and improving the quality of addiction treatment educating physicians, the public, supporting research and prevention, and promoting the appropriate role of physicians in the care of patients with addiction. So the ASAM is a great resource for you. They have a website. I highly suggest you go to that. And one of the things that they do, one of their education, services is this definition. And they recently updated it. I think it was 2020, but it could have been 2019. And if you go to their site, if you're interested, you'll see they have a short definition and a long definition. Don't get worried. Their long definition is not too long. It's like 3 pages, but it helps give the research and what they put into coming up with this definition. So the change that they recently made in the definition of addiction focuses, and if you'll look at the 4th word in this definition, addiction is a treatable. I should have highlighted that, but that is one of the big changes and one of the big promotion efforts that they want to make, is that addiction is treatable, and seeing it as treatable helps decrease stigma. So it's a chronic medical disease, and it impacts people's lives. And then I highlighted a couple of words in the definition that I really want you to pay attention to. We're going to come back to these later as we explore once we get stigma and addiction together. So people with addiction use substances or engage in behaviors that become compulsive, right? And we're clinicians here, so we all know what that means, and often continue despite harmful consequences. So embedded in the definition of addiction itself is that difficulty with control continuing despite harmful consequences. And prevention efforts and treatment approaches for addiction, they're generally as successful as those for other chronic diseases. So that's our definition. Then we want to go to clinical diagnosis. Clinical diagnosis. So we've done definition. Now we go to diagnosis. We're not going to, this is just a quick primer. The old diagnosis, and this becomes relevant later, the old diagnosis that was used in our, the way that we diagnose here, the DSM, now we're using the DSM-5, but the DSM-4, and then it was 4R, and then I think 4TR, lots of different books that we had to buy back in the day. But the old diagnosis in the DSM categorized what we think of as addiction in that definition into 2 diagnoses: substance abuse, which was the less severe one, and substance dependence. And I still see many people referring to substance abuse. That is not the current diagnosis under the DSM-5. The current diagnosis, number 1, wanted to not use stigmatizing language. The word abuse, as we'll see, has a lot of connotations for us with, if you think of abuse and I ask you to free associate, many people will say child abuse, physical abuse. So it has a very negative societal connotation and has become stigmatizing. So they wanted to change that language, and they also had some research that looked at these 2 diagnoses they had, substance abuse and dependence, weren't really discrete things. They were really looking at one thing on a continuum. So that's what we have in place now. The DSM-5, the diagnosis is substance use disorder. There are 11 criteria under that diagnosis, and they generally fall into 3 categories: failed efforts and issues around controlling. So pay attention to that word, right? We've already seen it mentioned in the definition. Failed efforts around control, having consequences, and craving are 3 C's. The criteria, if you meet, then there's this severity rating. So it's substance use disorder, and then it's either mild, moderate, or severe. 2 to 3 criteria, mild, 4 to 6 moderate, 6 plus severe. So that is our diagnosis. Prevalence. I talk about prevalence because, and I coach students all the time, and healthcare professionals, you must know something about substance use disorders. It is one of the most prevalent diagnoses that there is. So you need to know something about it. And if this was live, I would ask for a show of hands, who has either experienced a substance use disorder, had a family member with a substance use disorder, had a friend with one, or treated somebody who has a substance use disorder. And if I asked that, I think absolutely everyone in the audience would raise their hand. Every one of us has known or had some sort of touch with a substance use disorder. It's not this little obscure disorder that Dr. House has to investigate, which we could do a whole nother presentation on him and substance use disorders. But so it's prevalent. When we look at lifetime prevalence in the US, as you see, 29% of US adults, now this is lifetime, have at some point met criteria for an alcohol use disorder, and about 9.9 have met criteria for another substance use disorder. When we look at just a single point in time, like right now, if we went out, how many people in the United States right now, percentage, have a substance use disorder? The studies vary when they present that, but around 8 to 10% has been a stable number for over 20 years. So, and when we look at hospital population, hospital census, so in other words, how many people hospitalized here at UAB today would meet criteria for a substance use disorder, that prevalence goes up from 20 to 25%. So if you're working in healthcare, you need to know something about that. And then etiology. There are many factors that contribute to this disease. Too many for me to go over today, but some of the important ones and some of the factors that leave people vulnerable. When we talk about the disease of addiction, we speak in terms of vulnerability. What are the factors that leave people vulnerable to developing this disorder? And the most vulnerability comes from genetics. This is important for you to remember later, but the most vulnerable, or the biggest vulnerability factor, genetics. And that accounts for about 40 to 60% of the risk. And then there are other vulnerability factors, a few of them males, more likely. Comorbidity leaves people much more vulnerable, and that goes both ways. People, if they have a substance use disorder, are more vulnerable to have other mental health diagnoses. And if you have a mental health diagnosis, you're much more vulnerable to developing a substance use disorder. And then trauma and stress. Now, trauma and stress that can be current or childhood are vulnerability factors for many mental health and physical medical diseases, but they're also a very big vulnerability factor for substance use disorders. And then just a couple of references to, looking at substance use disorders generally. We know, and I didn't do a slide on the harm that alcohol and drugs cause to those who use them, their families, and society, because I think we all know that. I think, your healthcare professionals, and you have seen, you have lived, or you have worked with that harm. I did find this interesting, not at all, 2010, when it rates the overall harm to users and others by substance. And if we look at the top three here, remember we're getting to stigma with substance use. So if we look at the top three harm to themselves and others, alcohol, heroin, and tobacco, of course, are our top three. And out of those, 2 are the legal ones. And so when I referenced again, what is the most stigmatized health condition in surveys worldwide? It's illicit drug use, meaning not legal drug use. But if we look at harm, that doesn't actually add up. Alcohol and tobacco are in our top 3. All right, and then just to show that it costs a lot of money and is something very worthy of our time and our attention and our efforts. So we know there's harm, but there's also cost when we look at economic cost to society. And of course, all diseases have a cost to society. And there's a reason that we look at treatment and we do, public health campaigns. So by far, substance use disorders cost us the most in dollars. And I just want to give a shout out to, I work on the treatment side. And so that's once somebody has developed a substance use disorder, and we want to intervene at that point, of course. That's my life's work. But I want to give a shout out to the Addiction Prevention Coalition, because prevention efforts are very important as well. And they're, that has not been my area of study, but there is research out there. Prevention efforts work. There are evidence-based prevention methods out there, and the APC uses those, and it's great work. So we want the prevention side, and what we can't prevent, we want folks on the treatment research side. All right, so let's bring it together. It's time. We've defined stigma and addiction, and we've looked at some pieces between both of those, but let's bring it together. There's a great article, and it's from 1996. It was written by Dr. Alan Leshner. The article, it was in Science magazine, if you need the full reference. I should have put that in there, but it's called Addiction is a Brain Disease and It Matters. Dr. Alan Leshner. At the time that he wrote this, he was head of, and wait for it, it's that old term, but it was 1996. He was head of the National Institute on Drug Abuse. So he wrote this article about the biggest barrier in treating addiction, and he said it's stigma. He said we have the science behind being able to treat this disease, knowing it is a disease, and what we can start to do to help people with it. But he said, we have a big roadblock here, and that roadblock is stigma. And he was a really wonderful person, lecturer, and very plain-spoken New Yorker. And in this interview that I also saw, he just said, people hate addicts. They're afraid. They're afraid the addict is going to steal their stuff or do something for them or act in these ways that we don't like. But he said, whether you like them or not, they're a person with a disease, and that disease needs treatment, and that is the answer. So that's kind of our first takeaway, is one of the biggest barriers to doing the work that we need to in treating addiction is stigma, and people not seeing it as a disease. And I cite this because this was 1996, and today this is just as relevant. As I stated earlier, just a few minutes ago, when we look at worldwide surveys, illicit drug use is still the most stigmatized health condition in the world. And so here was Dr. Leshner saying, we're ready to change this. We have the science, it's a disease, we know how to approach it. And 25 years later, we haven't turned that corner yet. Okay, so why are we here today? I think because you care about this topic. I know I do. But the stigma associated with addictions and its effects contribute to, as we said, morbidity, poor care, and treatment resistance and dropout among our patients. So it's very important as healthcare professionals that we understand addiction, the associated stigma, and that we know how to reduce that within ourselves, others. Of current note is the COVID crisis and the impact that that has had on our friends with substance use disorders. You know, we all know we had the opiate crisis, and there was a lot of attention and news and some money and a lot of intervention that started to come out of that crisis. The crisis is a terrible thing. The good thing was that people started to respond and say, okay, instead of putting people in the corner and turning a blind eye, let's embrace these people and see what we can do to save lives. And the Addiction Prevention Coalition has been huge in that effort. Well, as we know, another crisis came along, and the COVID crisis. And of course, I'm not saying this is a bad thing. Of course, resources and news stories shifted, and they should have. The COVID crisis is unprecedented. But the people with substance use disorders didn't go away. In fact, they died more often. So if you look at some data from the CDC, overdoses are increasing, and people attempting to go to treatment has decreased. So I think post-COVID, we may have, this huge substance use disorder crisis again on our hands. Some of that is just, as we said, resources were needed to deal with what was happening in our world with the COVID crisis. Some other factors, COVID has been very isolating, and recovery happens in community. So there's been an impact there. And COVID and the crisis that's happened worldwide has also been stressful and traumatic. And so there has been an increase in substance use, not disorders necessarily, but substance use. There was a great story on NPR yesterday that alcohol use is on the rise, especially in women. And they had, the story about how to kind of look at that and see if this is an issue for you. So substance use is on the rise, substance use disorders, that people are having less access to care and financial resources, and we've seen a lot more overdoses and a little bit more stigma when our substance use disorder friends try to engage with services. Hospitals, ERs are packed with people who are ill with COVID or related illnesses. And so the stigma has returned. Those with substance use disorders, you're not really sick, you're taking up a bed. We need to, work with the people who are very critically ill here. So I think this is a very timely moment. And I just also think it's a very wonderful thing that so many of you came to spend 2 hours to look at this today. I'm really thankful. I'm touched. I take it as a very good sign. And I just want to thank you for your effort in this area. It's needed, and you're doing it. So how did we get here? How did all the stigma develop around substance use? Well, it's multifactorial. I don't have all of the answers, but as I've looked at that, there are a few possible things that contributed. So mental health care and medical care, started being separated out. Of course, mental health care was not even, really addressed early on. If it was through medical means. And so they started separating the medical and mental health in the 19th century. The good thing about that was that there was some specific care and interest in working in mental health. some of the downsides of that is that having these separate facilities made it seem that, mental health illnesses are strange. We don't want to have them with our regular medical patients. Mental health practices at first, there was a lot of trying to figure out best practice. And so sometimes mental health treatment was seen as, soft science. They're not real doctors. These aren't real patients, and they're dangerous. They need to be separated. In the early 20th century, we had the criminalization of drug and then alcohol. I put use, but it wasn't really around the use. The Harrison Act of 1914 was a tax act that taxed and started to regulate prescription and production of opiates and cocaine. Sadly, with that act, there was a lot of stigmatizing of users, those who used. There was a lot of racist rhetoric that went along with that. And it also started to have that idea that those who use are criminals. There's something wrong with them. We've got this act now. And of course, we know about prohibition, which was not just in the United States, and that was in 1920. And so it outlawed manufacture, sale, and transport of alcohol because it's terribly, dangerous stuff. We can't have it. We're not going to have it brought into this country. We're not going to sell it. People were allowed to enjoy it if they had any left over, but they weren't going to get any new stuff. And so, number one, we have this idea that those who drink, that it's this terrible, dangerous substance that we're not going to bring into or have in the country anymore. And of course, it didn't stop people drinking at all. So now there was this whole illegal alcohol trade. And another contribution was, you see my lovely poster here from President Nixon. And he declared the war on drugs 1971. We have this propaganda poster here, very scary. Public enemy number one in the United States, drug abuse. You can see his look. He's going to get those people. They're dangerous. And so public enemy number one, right? Drug abuse. There's a great interview about this war on drugs, how it came about, who it really impacted. And it's a former general who served, I think, in the Clinton administration. And in the interview, he starts to explore this metaphor and how it falls apart. If this is a war, who are we fighting? What are the weapons that we're employing? And what's our end game? How will we know when we win? And so, as you know, there's been a lot of fallout from that war on drugs. And luckily, policy is changing some to where we know that we can't punish our way out of substance use disorders. So that's some of the background. How did this become so stigmatized? Some factors that just influence stigma in general are cause and controllability, right? If we see the person as having something, a disease, some behavior, and it's not their fault, and they can't help it, you're going to see a decrease in stigma. If we think it is their fault, they did it to themselves, and if they wanted to, or if they were strong enough, they really could stop it, we're going to see an increase in stigma. So these are some factors. And if I want to look at it in this beautiful little chart that I didn't create, but I like to use. This is from the Recovery Research Institute. It shows and I want you to remember this, I want you to kind of keep this picture in your mind, the relation between cause and controllability in producing stigma. And so it just shows it as a product of each other. So the more we think somebody could control it, right? And if we're talking about substance use, I've heard a million times, if they really loved their family, they would quit. So there's a lot of that out there. So the more we think that they can't control it and it's not their fault, you can see stigma reducing. So the reason I want you to remember this is as we come back at the end, when we get to the wonderful part about what we can do, we want to work to reduce stigma. So to do that, we're going to have to work on those educating and understanding cause and controllability as it relates to addiction. So remember that. We will come back to it. Okay, we're going to take a little not break, but we're going to do something a little different so you can not hear me talk for a minute, which is exciting. And I want to just make it personal. We're going to take just 3 minutes, and Ashley, if you will time it when I tell you to time it. And each one of you is going to write about a time when you experienced or witnessed stigma in action with as much detail as possible, including how did you feel, what stands out to you, and you are not going to share this with the group. No one is going to see this if you don't want them to. I'm not going to ask people to share what you wrote. So please make it personal and please make it real and detailed. I get to work here at UAB with a wonderful group of artists in the Arts and Medicine program. And one of them, Salam, is a poet. And when she does writing prompts with us, she's done it with the staff and with patients, she tells them, don't worry about your spelling. Don't worry about your grammar. Nobody's going to see this. Just put your pen to paper and don't pick that pen up from the paper for 3 minutes. So you're going to write for 3 minutes. Afterward, Ashley will sort you into a breakout room. And for 5 minutes, you'll share with your breakout room group just your reaction. You don't have to share anything you wrote, just what came up for you. And then you'll elect a leader, and that leader will type something in the chat. And after, we'll look at that. So I'm going to leave these directions up here. And Ashley, will you time us for 3 minutes? All right, come on back, y'all. And thank you for doing that. Ashley is going to sort you into breakout rooms. Please share just a reflection, a thought, something you noticed. Pick a group leader. When we get back, we'll take 1 second, put it in the chat to look at what came up. Please be a good Zoomer. And when she sorts you into the rooms, show up, turn on your camera, and take just a couple of minutes to process your own personal reflection on stigma.
Okay, so we are actually having a small Zoom snafu, and Zoom is not allowing us to sort our folks into breakout rooms. So if they could just drop a couple thoughts in the chat, nothing too extensive, that would be wonderful if they feel comfortable with sharing with the group.
Okay, so let me guide that a little. What I want you to do and what you were going to do in the breakout room, again, you don't have to read what you share, but just reflect on that and share some feelings, thoughts on your personal experience with stigma. And we'll let Ashley, if you can, as people type that in, if you can share a few of the themes and thoughts that stand out.
Of course. Okay, yeah, so I'm seeing a couple people sharing that the feelings that actually come up for them when they see stigma happening. And one person said that the anger that comes up for them inhibits their ability to counter it effective. So address it with whoever is stigmatizing a group.
Yeah, anger is a very common feeling when we see that happening in practice.
Oh, and here is a great one. It said that the perception that people in recovery are damaged goods and not given the same options to move up in leadership. which that's something we'll chat about in just a few minutes when we watch the video.
It's very real. It's very real. And there's still a lot of fear around folks that have experienced a substance use disorder after they're sober. Yeah. Okay, we'll have time for one more and we'll move on.
Yeah, a lot more people are just sharing the frustration that it comes with seeing people be stigmatized, and then the limits for folks in the treatment and recovery process.
Yeah, yeah. And a lot of the limitations that we see out there are a direct result from it being stigmatized, and we'll talk about that. So thank you all. And we'll have one more little breakout, non-breakout later, but right now we will shift gears and just look at the impact on care, which you've already identified in that chat, and that's kind of part of the point of it. So what we believe as people, as clinicians, as healthcare professionals, if our beliefs around control and causality, people can control it, and they did cause it, that leads us to have some stereotypes and labels. And then that can impact the care our patient receives and many other things as well. So when we look at reducing stigma, if you remember that first chart, we want to look at the beliefs piece, control and cause. Then we also want to intervene with the stereotypes and labels. So that we can, if we want to change the care the patient receives, we work it backwards. We work first on our stereotypes and labels, and then we work it to changing what people believe. So this is sort of the process. And we've started with that today, looking at the beliefs. So, just to sum up, when stigma exists, there's evidence out there, patients are less likely to seek treatment and less likely to even complete treatment. They are more likely to hide what's going on with them because of fear being stigmatized and very real consequences. And once they start to hide the addiction, that plays into people's beliefs. They're all liars. They won't tell you what's really going on. We see public policy makers don't want to invest in something that they think, is controversial. So we see care impacted, and even research dollars may not be funneled into something if we think this is about people who did it to themselves and could quit if they really wanted to. They had enough willpower. So these are some of the impacts, and probably some of what you were seeing and what you were sharing that can be very frustrating to you. Just one of the studies that looks at this, looks at stigmatization of alcoholism and the impact on treatment seeking. So this was a nationally representative sample of over 34,000 adults who had a diagnosis of an alcohol use disorder, and they looked at the 34,000 adults with the substance use disorder, to what extent they perceived stigma, and then the outcomes of that. And so, it's what we would all expect. There was, in terms of treatment utilization, so just going to treatment, there was more treatment utilization in the lowest stigma group, right? So the more perceived stigma from a patient, the less likely they are going to seek treatment. And there's another good study, we just don't have time to go over all those today, that shows actually treatment completion is also impacted if there is perceived stigma. So that's once somebody has already engaged in treatment, if they perceive that staff has stigmatizing attitudes towards them, they drop out, right? So it impacts getting there in the first place And we want people to get there because, as we've shown, there's a lot of harm to the person, to other people. It costs a lot of money. So we want people to go to treatment, and we want them to stay in treatment, get the care they need. And stigma impacts both of those things. All right, let's look at another study. This study is a survey. So it's a study that actually culled results from 28 other studies. Stigma and beliefs and attitudes in healthcare professionals, has been highly studied. So this study kind of rounds up a lot of other studies. And what it shows is that healthcare professionals many are found to have very negative attitudes towards patients with substance use disorders. They haven't been trained in dealing with substance use disorders. And it was an old colleague of mine, and her belief was that one reason that people get so frustrated with those with substance use disorders is because they haven't been trained how to talk to them, what are the resources, what you can do to intervene. So, it's not our healthcare professionals' fault, really, if we're not training them in what to do. And the healthcare professionals were also found to be more avoidant when it came to substance use care. And so they might not visit as much, less empathy, less engagement, less time spent. So if you were interested in reading this review, we have the reference up here for you. But I liked it because instead of just being a study, it was a review of studies, and it just kind of shows you that overall impact. So, all right, as we've said, perceived stigma in hospitals or doctors' offices can discourage people from getting health care. Studies show that nurses, specifically, obviously it's healthcare and professional. These two studies just happen to look at a nursing population. Okay, so it's not just nurses. These were just studies around nursing, and showed the majority of the nurses that they studied had negative views about people who use drugs, and especially some studies have shown that the stigma is even greater if the substance use method is intravenous. So when we as healthcare providers have a stigmatizing perception of our clients, it just really impacts their care, coming to treatment, staying in treatment, how we approach the patient, how much time we spend with the patient, and the resources that we offer. All right, so we get to, I hope this works because I know you want to listen to somebody besides me for a minute. We're going to hear a personal account of the impact of stigma. As I said early on, I'm not in recovery. I'm an ally for people in recovery and people with substance use disorders. So whenever I do a presentation, I want to be sure to bring the voice of recovery into the room. Sometimes, as I said, I have people who work with me and for me in recovery, and many times they will be that voice. They certainly helped contribute to this presentation, so they were a voice in the room in that way. But today we're going to have the literal voice of a person in long-term recovery, and it's a TED Talk by Michael Botticelli. He is in leadership in the Recovery Research Institute, and he's also the former director of the White House Office on National Drug Control Policy under the Obama administration. I think he took that office in 2014. And I joked to Carrie and Ashley, I was like, maybe just don't even have me do this presentation. Just show this TED Talk, because he says everything I want to say, but so much more beautifully and with this personal story. So just in case it impacts it, Ashley, I'm going to stop my sharing. And if you will play this TED Talk for us, that would be great.
innocent victims, and you probably wouldn't be able to.
All right, now can everyone see it?
Yes.
Can everyone hear it?
Yes.
Institutions.
Can you
Okay,
just
perfect. There
start
we
it
go.
from the beginning and that'd be great.
All right.
But my
We can't hear it again. I think you're not gonna be able to give it the full screen, Ashley. So if you can just stop it and just don't zoom in on it.
All right, so I'm gonna start it back and can y'all hear it
along
now?
the way.
Yes.
Okay,
see,
perfect.
I grew up in a family riddled with addiction. And as a kid, I also struggled coming to terms with my own sexuality. And even though I couldn't name it then, growing up as a gay kid just compounded my issues of isolation and insecurities. But drinking took all of that away. Like many, I drank at an early age. I continued to drink my way through college. And when I finally did come out in the early 1980s, about the only places to meet other gay people, to socialize, to be yourself were gay bars. And what do you do in gay bars? You drink. And I did. A lot. My story is not unique. Like millions of Americans, my disease progressed undiagnosed. It took me to people and places and things that I never would have chosen. You know, and it wasn't until an intersection with the law gave me an opportunity to get care that I began my journey of recovery. And you know, my journey of recovery has been filled with love and with joy, but it hasn't been without pain. Like many of you, I've lost too many friends and family to this disease. I've heard too many heartbreaking stories of people who lost loved ones to addiction. And I've also lost countless friends to HIV and AIDS. You know, our current opioid epidemic and the AIDS epidemic tragically have much in common. Right now, we are in the midst of one of the greatest health crises of our time. During 2014 alone, 28,000 people died of drug overdoses associated with prescription drugs and heroin. During the 1980s, scores of people were dying for HIV and AIDS. Public officials ignored it. Some wouldn't even utter the words. They didn't want treatment. And tragically, there are many parallels with our current epidemic. Some called it the gay plague. They called for quarantines. They wanted to separate the innocent victims from the rest of us. I was afraid we were losing this battle because people were blaming us for being sick. Public policy was being held hostage by stigma and fear. And also held hostage were compassion, care, research, recovery, and treatment. But we changed all that. Because out of the pain of those deaths, saw a social and political movement. AIDS galvanized us into action, to stand up, to speak up, and to act out. And it also galvanized the LGBT movement. We knew we were in a battle for our lives because silence equaled death. But we changed, and we made things happen. And right now, we have the potential to see the end of HIV and AIDS in our lifetime. These changes came in no small part by the courageous yet simple decision for people to come out to their neighbors, to their friends, to their families, and to their coworkers. Years ago, I was a volunteer for the Names Project. This was an effort started by Clete Jones in San Francisco to show that people who died of AIDS had names and faces and families and people who loved them. I still recall unfolding the AIDS memorial quilt on the National Mall on a brilliant day in October 1988. So fast forward to 2015, the Supreme Court's decision to strike down the ban on same-sex marriage. My husband, Dave, and I walk over to the steps of the Supreme Court to celebrate that decision with so many other people. And I couldn't help but think how far we came around LGBT rights, and yet how far we needed to go around issues of addiction. When I was nominated by President Obama to be his director of drug policy, I was very open about my recovery and about the fact that I was a gay man. And at no point during my confirmation process, at least that I know of, did the fact that I was a gay man come to bear on my candidacy or my fitness to do this job. But my addiction did. At one point, a congressional staffer said that there was no way that I was going to be confirmed by the United States Senate because of my past. Despite the fact that I had been in recovery for over 20 years, and despite the fact that this job takes a little bit of knowledge around addiction. So, you know, this is the stigma that people with substance use disorders face every single day. And you know, I have to tell you, it's still why I'm still more comfortable coming out as a gay man than I am about a person with a history of addiction. Nearly every family in America is affected by addiction. Yet, unfortunately, too often, it's not talked about openly and honestly. It's whispered about. It's met with derision and scorn. We hear these stories time and time again on TV, online. We hear it from public officials and we hear it from family and friends. You know, and those of us with an addiction, we hear those voices. And somehow we believe that we are less deserving of care and treatment. Today in the United States, only 1 in 9 people get care and treatment for their disorder. 1 in 9. Think about that. Generally, people with other diseases get care and treatment. If you have cancer, you get treatment. If you have diabetes, you get treatment. If you have a heart attack, you get emergency services and you get referred to care. But somehow people with addiction have to wait for treatment or often can't get it when they need it. And left untreated, addiction has significant dire consequences. And for many people, that means death or incarceration. We've been down that road before. For too long, our country felt like we could arrest our way out of this problem. But we know that we can't. Decades of scientific research has shown that this is a medical issue, that this is a chronic medical condition that people inherit and that people develop. So the Obama administration has taken a different tack on drug policy. We've developed and implemented a comprehensive plan to expand prevention services, treatment services, early intervention, and recovery support. We've pushed criminal justice reform. We've knocked down barriers to give people second chances. We see public health and public safety officials working hand in hand at the community level. We see police chiefs across the country guiding people to treatment instead of jail and incarceration. We see law enforcement, others, and other first responders reversing overdoses with naloxone to give people a second chance for care. The Affordable Care Act is the biggest expansion of substance use disorder treatment in a generation. And it also calls for the integration of treatment services within primary care. But fundamentally, all of this work is not enough unless we change the way that we view people with addiction in the United States. You know, years ago when I finally understood that I had a problem and I knew that I needed help, I was too afraid to ask for it. I felt that people would think I was stupid, that I was weak-willed, that I was morally flawed. But I talk about my recovery because I want to make change. I want us to see that we need to be open and candid about who we are and what we can do. You know, I'm public about my own recovery, not to be self-congratulatory. I am open about my own recovery to change public opinion, to change public policy, and to change the course of this epidemic and empower the millions of Americans who struggle with this journey to be open and candid about who they are. You know, people are more than their disease. And all of us have the opportunity to change public opinion and to change public policy. All of us know someone who has an addiction. And all of us can do our part to change how we view people with addiction in the United States. So when you see someone with an addiction, don't think of a drunk or a junkie or an addict or an abuser. See a person, offer them help, give them kindness and compassion. And together, we can be part of a growing movement in the United States to change how we view people with addiction. Together, we can change public policy. We can ensure that people get care when they need it, just like any other disease. We can be part of a growing, unstoppable movement to have millions of Americans enter recovery and put an end to this epidemic. Thank you very much.
Because everything great is birthed through discomfort. Real empathy says, I see you, I feel you, I hear you.
We're still carrying on. Okay, there.
Yay, thank you, Ashley. And I know it is so hard when our technology doesn't work, but you did a great job. Thank you all for sticking around to hear that. I just find it a very timely, moving talk. And again, he says everything that I want to say, but better. So I saw some comments as he was speaking, and people had chills, and people seemed to get the comparison there and what he was saying. So Ashley, if you see anything else in the chat that you wanted to share on that reaction to his talk, let me know.
All right, and I will share the link to that video in the chat shortly.
Thank you. So I want to get into, I see the time and I know the direction we want to go, and the direction I want to go is, and I'm sure you do as well, what can we do? So just a couple of other things when we look at stigma and the components of it. I want you to all, which I'm sure you are, be aware of both omission or commission. Lots of times commission, acts of commission is what we pay attention to and see, but there are things that happen very subtly, those acts of omission as well. So we've listed them up there and how they can come out in public policy, care of our patients, and just things for you to be aware of. All right, Michael Botticelli introduced the idea, and as we talked about, eventually we're going to change and reduce stigma. We're working on the beliefs, but we also work on the labels and stereotypes. So we're just going to take a minute or two, and I'll have you type in the chat. What have you heard? You know, what have you heard? The worst you've heard, stigmatizing language and references to using people with substance use disorders. What have you heard? What's out there? And Ashley, you can kind of summarize as it comes up for us.
Yeah, so I'm seeing some of the common ones, and one of the ones I know that I hear often is it is a choice and not a disease.
Sure.
And then just some of the, names that people call people that use certain drugs, like crackhead, meth head, let's see, junkie is a word that's very common that people are pointing out.
And I thought junkie was an old one, but I hear crackhead and meth head a lot.
Yeah.
And people that are using it with me are sometimes even advocating for the patient, but they're still using that stigmatizing language. Yeah.
Ooh, this is actually a really great one that people have pointed out, that people use stigmatizing language in saying they and them. Well, they are just a drug addict, or why give them Narcan?
Yes, and we had a program in the ER that we were developing, and it was around getting Narcan kits into the hands of those who'd overdosed or their families. And there was a healthcare worker there, and she was very upset. And she was like, "This, this isn't helping them. This is just making what they're doing okay. And are we giving the same help, to diabetics?" And of course we are giving that same help in different ways to those with diabetes. So yeah, I hear that one as well.
And another great one, and this is something that come up in the chat earlier, was someone pointed out methadone clinics are just legal drug use, and the
Mhm.
stigmatizing language that comes with medical assisted treatment.
Yeah, good job. So from previous presentations, had somebody create this word cloud for me, and it includes many of the things that y'all shared in the chat, just these common stereotypes, some of these names. And like I said, I didn't know junkie was still one, but I've certainly heard, that's wasting a bed, drug seeking, crackhead, meth head. Yeah. So I thought to myself, yes, language is important, and we'll get into that more, but we're a digital society, and images are important too, right? And they influence us, and there are stereotypic images as well. And so a colleague of mine, as we were discussing this presentation, he was like, "Why don't you Google it? Like Google and see what comes up when you just type in." We just typed in addict and picked the top 2 images, and then we typed in alcoholic. And so here's what Google thinks that substance use disorder is. These are the sort of stereotypic images that you find with just a quick search. And as we know, and as Michael Botticelli said, lots of times there really is no portrait or poster child for the disease. Addiction looks all kinds of different ways. It looks like this, right? But it also is somebody who walks into a hospital in a white coat, but is broken inside, as he said. It cuts across racial lines, socioeconomic lines. There is no link to level of education. So it's just important for us to know that there really is no one face or image. And I was doing this presentation, and as you know, we're about to get into the what can we do part. And I thought, well, I wonder what the image would be if I searched a substance use disorder. So this is Google and what they think of addict alcoholic when I type it in, but look at what they think when I put substance use disorder. This lovely little graph came up, just looking at incidents. So the power of words, even Google responds. They have what they think of with addict and alcoholic, and look at the difference when you type in substance use disorder. So let's dive into that a little. Any thing from the chat, Ashley, that I should pay attention to before we shift gears?
Nope, just people pointing out some of the discrimination that occurs also with addiction and treatments.
Okay.
But lots of good comments. We have a very bright group today.
Awesome. And thank y'all for your participation. Makes it more fun.
Bronwyn, is there a replacement word for relapse? Or is relapse a stigmatizing word?
Relapse right now is still, and we'll get into that, clinically correct language.
Okay. That was one of the questions.
It's a great question. I love that question. And it shows a lot of care and that people are interested and want to make a change. So I think we're going to skip the breakout room. I think y'all, that was not working to sort people in, and y'all have really shared some of what we wanted you to in the chat, which is just, you know, thinking about practitioners. If we use the language that we showed in the word cloud, or if we hear that language, how does it impact us? How does it impact our patients? You know, if they overhear us, they see it in a chart. But I think you have all really shared that. So we know words matter, and I just want to show you how much they matter. So the next is, I'm going to share a study, and it's a study out of the research, the Recovery Research Institute, and the lead researcher is Dr. Kelly, who's spoken for us before. He's great. So the study shows us quite pointedly the power of words. So, does our choice of substance-related terms influence perceptions of treatment need? An empirical investigation with 2 commonly used terms. Okay, so what's the study? The study is they gather, I think they had an N of 350 people. And they divide these people into 2 groups. And each group gets a little piece of paper with a vignette, a little story about Mr. Williams. And they don't give much information about Williams. They don't tell you his age, his race, his anything, just Mr. Williams, right? And so the 2 groups get this little story about Mr. Williams, and they're exactly the same, these 2 stories, except one says, Mr. Williams is a substance abuser and is attending a treatment program through the court. As part of the program, Mr. Williams is required to remain abstinent from alcohol and other drugs. Fine. The other vignette's exactly the same, but it just says, Mr. Williams has a substance use disorder, is attending treatment, yada, 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 right? So they gave these 2 little stories to the 2 groups of people. They had to read the story, and then they had to answer some questions about Mr. Williams. Do you think Mr. Williams would benefit from treatment? Would you be scared of Mr. Williams? Da, 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 da. And they took all of those questions that the 2 groups answered, and they kind of lumped them into categories. And I just want you to show you this difference because it's really striking. And it's really exciting, actually, because words do have power, and it doesn't cost us any money to change the language. It doesn't even, you don't have to do that many, even more keystrokes to enter has a substance use disorder versus substance abuser. So just take a look at this difference. They grouped those questions that they asked about Mr. Williams into kind of categories. And you can see if the group that got the description of Mr. Williams as a substance abuser, it's the little column in white. If he has a substance use disorder, that's in black. So the first questions were around, should he get treatment? And just look at how many more were convinced treatment was going to be helpful just from that phrase. We don't know anything else. He has a substance use disorder, much more likely to think treatment was going to be helpful. Mr. Williams, substance abuser in the court system. So there were questions asked about punishment. Much more likely to think punishment was going to be helpful and was appropriate for the Mr. Williams substance abuser. Questions were asked about, were they afraid of him? Would they want him in their neighborhood? So social threat. He was perceived as a much higher social threat if he was a substance abuser. And then look at that. Remember that chart of how we reduce stigma, control, and causality? Just changing the word that people read or the phrase. Much likely to think, more likely to think he was to blame, that he can control it and he was at cause if he was referred to as a substance abuser. And then self-regulation is just around, could he, control his actions, and some questions around that. But I think the big differences you see are around treatment, punishment, social threat, and self-regulation and blame. So I just wanted to highlight that. It's a very important study. So summary of the impact on our patients. And I think we all understand that and have looked at that this morning. So I'll let you read through that and then we'll get into what we can do. Our first opportunity, our second opportunity. All right, so let's look at clinical language and documentation. As we said, in reducing stigma, we have two big opportunities. And the first is around changing beliefs, right? Looking at cause and controllability. Addiction is a disease. And one of the defining components of it is difficulty with control, and etiology, mainly genetics. So we can address stigma in that way by educating ourselves, which we're doing, educating our peers, educating our patients, because remember, they're impacted by stigma, their own stigma of themselves. And the second opportunity we have is with those stereotypes and labels. And we've shown language is important. It impacts the way we think. Language that we use impacts our patients and their perception of us as stigmatizing. And we can be models of clinically correct, non-stigmatizing language and really make a difference. I do want to just highlight that when I'm talking about language and making a change, and I'm not talking about our patients. So our patients, people in recovery, I don't correct them about their language, right? I'm talking about us as clinicians providing the care, making sure that we use that right language, but our patients get to use and express themselves the way they want. So, and we can use documentation as a way to advocate for our patients. So you noticed earlier the study, substance abuser versus has a substance use disorder, and the big impact it makes. So think about broadening that out in a chart. I'm not going to share anything that's been written in a chart ever. I made up like a fake thing, but a fake vignette myself, but that pretty much sums up what I read in about 1 out of 2 charts that I review when I'm looking at the patients that we do consult on. So I just want you to think about documentation as advocacy and listen to these 2 handoff communications in a chart. Tell me what you think. So the first one, and I just picked patient Mr. Smith. So listen to this handoff communication. Mr. Smith is a long-term substance abuser and frequents the ER. He returns today complaining of being in withdrawals, but is in no obvious distress. He is clearly drug seeking as he is repeatedly asking for Suboxone. He always denies opportunity for treatment. Plan to discharge with standard comfort measures recommended. And those comfort measures are like, we're not going to give him his Suboxone. We'll give him some Tylenol for his headache, a little nausea med, you know, for this, for feeling sick. So, and think about that same description if we used clinically correct documentation and we thought about it as an opportunity to advocate. So here's the second one, and here's how we try to document when we're doing consults. Mr. Smith presents today with opiate use disorder severe. He is reporting withdrawal symptoms. His stage of change related to treatment is pre-contemplation. Plan to page for peer support to work on motivation and addiction medicine to discuss MOUD, which is medication for opiate use disorder. So just think about that handoff communication. And again, that first example, I have seen something similar a million times. And guess what? The person doesn't get their medication. They don't get support. And they're usually back very quickly in our system. Any thoughts or comments from that? Well, we just want to drill down a little bit more. I've picked a few recommended language examples, and this is really timely. I got an email last night from my manager, Beth Kane here, and the American Hospital Association just put out these public service posters that you can print that show correct and incorrect language regarding substance use disorder. So it's really nice that I think some of the literature and research on stigma is making it into the mainstream. So I picked a few, and I picked these because I hear them daily. And sometimes I hear them even amongst my team, some of whom are in recovery. So they're in that culture, but when we're operating in a chart or with the patient, we're the clinician. So, and we've all had the education about proper language, but I still hear my counselors, everybody sometimes saying, well, how much clean time do they have? So just some examples of what to say, not say, and especially in the chart and just modeling for the patient. You have this chart here. And so again, this is for us as the clinician. We're not trying to change what our patients say or shame them for using different, not clinically correct language. So clean is used frequently and widely, but as you can guess, if somebody's not clean, they're dirty. And dirty has a lot of negative connotations. So we do want to say a person in long-term recovery, or you could say, if you want to use the clinical term, substance use disorder in remission. And certainly in the chart, we want to use that. Drug abuser, I see that absolutely every day. And I hear people saying that, well, he's been abusing drugs for a long time. Again, abuse and abuser has very negative connotations. And as we've looked at, research shows that just changing that term, that one term, can have an impact on the way people think about our patients. So we like to use that person with a substance use disorder. Number one, it's clinically correct. Number two, it's person forward, right? If we have a drug abuser, what's the problem? The drug abuser, right? So that's the person becomes the problem. When we use that person first language, it's a person who has a substance use disorder, then the disorder is the problem, not the person. So think about that. Clinically correct, person first, non-stigmatizing. I hear a lot about dirty urines, and that's not clinically correct language. And it also doesn't give us as much information as the urine was positive for APC, right? Or the toxicology screen was performed, urine was collected and it was positive for A, B, and C. Heroin addict, again, if we say that, what's the problem? The heroin addict. If we use that person first language, then we are identifying the problem. It's the opiate use disorder. We can put in a severity qualifier. And the last one, it actually made it on the AHA poster as well that was sent to me last night. And I promise y'all, I hear this so often. Frequent flyer. And on our team, we have changed that. And that's through the influence of a certain person who did a presentation years ago. And she works in Georgia, Neil Campbell. I only say this because she says this. She's a person in long-term recovery and works with peers in Georgia and advocacy for recovering people. And so she has a lot of her peers work in ERs, and they work to change the culture by using different language themselves. So from frequent flyer, we refer to our patients who are here often as a friendly face, or we're like, they're our friend. Okay, our friend is readmitted. Let's go see him or her and see where they are, see what support we can offer. So these are just something you can start doing. You probably already are doing it, but you can do it today. It doesn't cost any money. And again, it's a way that our language can influence other people. And if we use this kind of language in the chart, it could actually influence our patient's care. All right. What other things can we do about stigma and discrimination with substance use disorders? Well, as we said, first and foremost, and we're doing that today, education, that addiction is a disease. It's a chronic disease, but we always want to stress that it's treatable. And somebody asked earlier about relapse and if that is a correct word. And it is a clinically correct word. And it may have some stigma attached to it, but I don't know that there is another, replacement word right now. When we educate patients and families, we help them understand that relapse can happen. It can happen in any chronic disease. If somebody experiences a dramatic event or kind of falls off doing some of the things they need to do to take care of themselves. I don't know about any of y'all, but occasionally I've fallen off of doing some of the things I need to take care of myself and my health. So any of us could have a relapse of a chronic medical condition, and we just need to normalize that with our patients. So substance use disorders, they're a disease, they're a condition, they're chronic, they're treatable, and relapse is treatable.
Roman, there's a comment that return to use is another option for relapse.
Okay, wonderful. Thank you so much, whoever posted that. I love that.
Also a comment about, and something we might want to consider for a future training is talking more in depth about the stages of change that you just mentioned in the description. That's, the knowledge around that they're interested in.
That is such an important part of working with folks with substance use disorders. And it's an important part, at least for my team, in understanding how we're going to intervene. And I did use that language in the chart example on purpose, because sometimes when we have a patient in pre-contemplation, meaning I don't want to make a change, the approach from healthcare can be, then we have nothing to offer you. But when you learn about stages of change, you know that there are things that we can offer somebody in pre-contemplation. And so it becomes less frustrating to work with our folks in pre-contemplation. So yes, in fact, I'm doing a presentation in June to the Center for Psychiatric Medicine here in UAB about motivational interviewing. And this is the second one I've done. And so we talk a great deal about that when we're looking at our interventions. So thank you. Sometimes one of the most stigmatizing things about substance use disorders is the behavioral component, what people do, what they don't do as a consequence of having this disease. And we just need to recognize that compulsion is part of the disease. So if we're seeing that behavior, it's somebody exhibiting the symptoms of their disease, not bad behavior. Make it personal, get to know people in recovery and their stories. Ask them questions. Today, we got to know a little bit of Michael Botticelli, but see, we have peers that work here, and they are a wonderful part of the program. The peers who work in my program are ambassadors, and they go hospital-wide, and their badge says peer support. And so the staff they interact with knows they're a person in long-term recovery, and they're getting to see their professionalism, their compassion, their correct clinical language, and the way that they can intervene with folks. And as somebody said, at any stage of change. So get to know. Yeah.
We actually have a quick question about peer support specialists at UAB. And Aaron asked if we have any Spanish-speaking peer support specialists at UAB, or if any, we do not? Okay.
That I know of. So I employ 4, and none of them are bilingual. Spanish-speaking peer support specialists would be wonderful. I've not, that I know of, had a bilingual person apply. We do have translation services here at UAB, both in person and via technology. So but it would be beautiful to have somebody who culturally and linguistically would be able to interact with our Spanish speaking patients. And finally, change our language terminology to be consistent with true medical condition of, true medical nature of the condition and the policies that we want to implement. And we've just looked at some of the big examples there. I personally, amongst my staff, if somebody was like, oh, they've been clean a long time, I'll say sober or in recovery, and remind them in the moment. If I'm working with other clinicians, I prefer to just use modeling so I don't correct people in the moment. And, but I do believe in, and I'm excited for the hospital campaign that's coming up, where there will be some in-unit public service posters about correct language with substance use disorders. So, timed it perfectly. We have 5 minutes left, and I would love to hear comments, answer questions, or just chat with you. And I will stop sharing so I can see the chat as well. Somebody said physicians could really benefit from hearing these webinars. I agree. I will say that sometimes I hear them and see in the chart them using not up-to-date language about substance use disorders. I work with many wonderful physicians, and it was one of them, Dr. Leah Leish, who works in our consult service, who shared with me just that specific phrase that I use today as the way we document is a way to empower our patients and advocate for them. Thank you. Somebody who said, excellent presentation. It's very nice. Someone said law enforcement. Yes, I think law enforcement understanding the nature of substance use disorders and some of the things that they can do if they have somebody in a crisis.
There was a question, Bronwyn, about, and this is certainly not something we can address at this moment, but why are we calling it a disease? The disease model. That probably is a whole nother webinar, but it does affect, stigmatizing, not understanding that concept.
Yes, absolutely. And that is a presentation in and of itself, the neurobiology of this disease. And there is wonderful, wonderful information on it. When I do that presentation, I'm a social worker and therapist. And so some of the neurobiology goes whoop, over my head, but I do present on some of those main takeaway points. And there is just so much good, beautiful information. And a lot of that information has been last 30, 35 years because of the improvement in technology and being actually able to look at in the moment brains. So, those live scans of somebody on drugs, after using drugs or alcohol. And there's a really great research study right now that's looking at and scanning people who are in long-term recovery. So what happens to the brain in recovery? And there's a lot of great information on that. Any questions? Thank you so much, all of y'all, for showing up, engaging in that chat. Thank you for being kind to me today. I was nervous and you all were so supportive. And thank you for just being interested in this. Ashley will send some of the I wanted you all to have a link to SAMHSA, which has some great information on language, and the link to the Recovery Research Institute, where I pulled these studies and some of them that do these studies. So she will send those links.
Yes. So once again, thank you for doing this presentation for us today. I dropped the link to the evaluation in the chat a little earlier. It may have gotten pushed back, but I'll put it in there again. And then, like Bronwyn said, I will be sending out an email that will have links that she used. And then there will also be another link to the evaluation as well. All right, and then if you guys need anything or you have any questions about CEs, I'll also drop my email in the chat as well. Thank you guys for participating.
Thank you so much, Bronwyn. It was fabulous.
Oh, thank you. And no Zoom meeting can ever be complete without the wave. Bye.
Thanks, everybody.
Research, why do we wave? I don't know, but I have to. Thank you all.